I shall now be talking about the safe stimulation protocol for the oocyte donors. I'll start with certain hard facts. The first pregnancy from oocyte donation took place in 1984. It was a patient who had primary ovarian failure. In the last decade, the ESHE data has shown that there has been 2.6-fold increase in the oocyte donation cycles. And you all would agree that currently oocyte donation gives the best pregnancy rates among all available ART procedures. Such are the ads that we do see in the newspapers, calling oocyte donation a human egg trading. We also have 2 deaths which have been reported. The first of Sushma Pandey, a 17-year-old girl in Bombay in 2010, and the most recent in Delhi of a girl called Yuma Sherpa, who was 24 years. It is highly unfortunate that these deaths have taken place because oocyte donation is a profession. It's not a disease. But we need to understand that this is just the tip of the iceberg. We have so many deaths and morbidity as well as mortality of oocyte donors which have not as yet been reported. Thus, as IVF experts, what is our perspective for the oocyte donation? The protocols used should be extremely safe for the donors. It should be very simple and it should be secure. Secure means it should be cost effective to us and it should give us good pregnancy rates. And what is the donor's prime focus? The donor who comes to us wants the protocol to be extremely convenient. It should be friendly to her so that she does not have several visits to us. And more importantly, there should be no unnecessary treatment risks involved. Thus, to have a very safe oocyte donation program, we need 3 things. First, it starts from the proper selection of the donors. Safe stimulation protocols have to be adopted, and more importantly, our program should include a donor follow-up. Coming to the first aspect, the selection of the donors. We have to follow the ICMR guidelines. At present, it is only in the form of a draft, hoping that it shall soon become a bill. The guidelines clearly states that when we take an oocyte donor, the age should be between 21 to 35 years of age. She should be of an average BMI. We do not want malnourished women to go in for donation. They should be well screened for all medical, mental, genetic as well as infective disorders. The ideal AFC in these patients would be between 10 to 14, and very important, we need to take a detailed history to illustrate that this woman has not had more than 6 donations and each donation should be minimum of 3 months apart. We as IVF experts, especially who deal with the oocyte donation sharing programs where one oocyte donor is being used for 2 women, should not be greedy. Using thin, lean PCOS donors, we are putting them at great risk of OHSs. Thus, we should not select thin, lean PCOS patients. When we come to the recruitment of the donors, we should always take them from registered agencies, the ones which are registered with the ICMR. A consent form should be signed based on the ICMR guidelines by both the donor as well as husband. More importantly, they have to be counseled. They have to be told what the program involves, what is the donor going to go through as far as injections are concerned, as well as the pickup is concerned. And importantly, the companies should get them insured as far as health is concerned, so that in case there is a problem, we do have a health insurance cover. The next important aspect for a safe stimulation protocol is selection of the protocol. What do we really need out of a protocol? It should have a very short duration so that it is donor friendly. Very low dose of gonadotrophins is required. We require very less of the intermediate follicles so that the risk of OHS is very less. An adequate number of mature oocytes, desirable fertilization rates, good implantation and ongoing pregnancy rates, and more importantly, not a single case of OHSs. Thus, if you put all these outcomes into one, we all would agree that the protocol of choice for these patients is the antagonist protocol. This protocol had come into clinical use in 1999, but since then it still has a low acceptability. And the main reasons is because of the concerns of the IVF specialist as to the number and the quality of oocytes retrieved and the implantation and the ongoing pregnancy rates. Thus, coming to the evidence. This is the latest Cochrane review of Al-Anani in 2011, where he had found that in an ANTAC cycle, the pregnancy rates is about just 1.5 to 2% less than the long agonist protocol. This is quite contrary to the one that was published in 2001, where they found that the pregnancy rate was about 5 to 10% lower. But since we have understood this molecule better, we have more studies, we have found that the rates are not significantly lower in normal, regular IVF patients. But when we consider the same thing with the oocyte donors, several studies have been done by Baudry et al. We have several retrospective trials, randomized controlled trials, as well as meta-analysis, and all of these trials have shown that in these particular patients, the favor goes for the ANTAC cycles, that the ANTAC cycles gives much better pregnancy rates as compared to the agonist cycles for the oocyte donors. The meta-analysis which had been published by Baudry et al. Also states the same, that the duration of stimulation required in an ANTAC cycle is much less and that there is no significant difference in the number of oocytes retrieved and the recipient ongoing pregnancy rates. In fact, this study did show that the pregnancy rates in the oocyte donors using ANTACs was little higher than those in the normal IVF patients who were using the ANTAC cycle. And the main reason behind this is that in a oocyte donation cycle, the recipient does not have the negative effects of the ANTACs, and hence the pregnancy rates are higher. Thus, to conclude, ANTAC cycle is the protocol of choice. The main benefit is that it allows us to use agonist trigger and thus finish off or completely reduce the risk of OHSS. Now coming on to the trigger. Which trigger is best for these patients, agonist or HCG? We all have been very used to getting HCG triggers because we feel that the oocyte maturity is much better, but the evidence to this is to the contrary. We have several retrospective cohort studies which have clearly shown that there is no significant difference in the proportion of mature oocytes and the fertilization rates, as well as implantation and the ongoing pregnancy rates. And the more important factor that whenever we are using the agonist trigger, the risk of OHSS is negligible as compared to the ones where HCG trigger was used, where the risk of OHSS was found to be approximately 5.7 to 7%. The same has further been emphasized by the randomized controlled trials, and the latest study by P. Humane in the Cochrane in 2011. The heading of the study itself says, GnRH agonist for triggering of final oocyte maturation. Time for change of practice. And they have recommended that in the oocyte donation cycles, agonist trigger is the trigger of choice. It has no disadvantage, and thus this is the trigger that should be used in all oocyte donors. Further, they have claimed that using this trigger, the additional benefits of shorter luteal phase, reduced ovarian volumes, diminished abdominal distension in the donors, and practically for the IVF centers, we require less cycle monitoring. There is no need for cycle cancellation, and no interventions are required for decreasing the risk of OHSS. Now coming to the complications and risks which an oocyte donor is exposed to. The complications of oocyte retrieval is comparatively very low. It is only about 0.35%. And as far as the risk of OHSS is concerned, the risk is only when the HCG trigger has been used, and they are only exposed to the early onset OHSS as pregnancy does not take place in these patients. For preventing any risk, OPU should be done by an experienced IVF specialist. Cabergoline albumin can be considered if we expect any risk of OHSS, and ANTACs are used after an OPU. The donors should be observed for a minimum of 2 hours in the IVF center after the OPU. We should call them up in the evening and ask them how they are, and again see them up after 2 weeks. Counseling before discharge is very essential, where we tell them that they should avoid sexual intercourse for a minimum of 15 days or till the next periods. And we should also tell them what are the symptoms of OHSS when they need to report to us immediately. Thus, I would like to end by saying it's a time to change over completely to antagonistic protocols for oocyte donation for the purpose of donor convenience and safety, as there is no difference in the ongoing pregnancy rates. We have to use the GnRH agonist trigger in all oocyte donors. If we are still reluctant, at least in high-risk OHSS cases, this is the protocol of choice. I would just like to share our experience at IVF. We have nearly 30% of our cycles which are oocyte donation cycles. We strictly follow the ICMR guidelines while selecting the oocyte donors. Only flexible ANTAX protocols are used, and we too just use the agonist trigger in cases where we suspect that they are at high risk of OHSS, and our ongoing pregnancy rate is nearly 50%. The world is changing. From moving on to agonist cycles, at present, nearly 60 to 70% of all our cycles are ANTAX cycles in oocyte donors, and the triggers are being used in nearly 70% of these cases. If we at Lifecare have changed, if the world has changed, then why not each and every IVF center? I would just like to say, we should not resist the change. We all should embrace it. Thank you.